Hello and welcome to the ERAS4OLT.org project. In this presentation, we will introduce the project and give a more detailed insight into its methodology. ERAS4OLT stands for Enhanced Recovery for Orthotopic Liver Transplantation. This study will provide highly valuable data on enhanced recovery after both deceased donor and living donor liver transplantation. It represents a multidisciplinary collaboration of experts worldwide and applies the Danish Model of Consensus to bridge the gap between experts, for which we will go into more details later in this presentation. The chairs of this project are Michael Spyro and Dimitri Raptis, and the chief investigators are Klaus Niemann, Jörg Matthias Pollock, and Marina Berenguer. This project is conducted in partnership with the International Liver Transplantation Society, working with the University College of London and the Royal Free London NHS Foundation Trust. It is sponsored by Edwards, the Royal Free Charity, and Royal Free Pre-Operative Research. As an international collaboration project, it involves experts from 4 continents working together to create internationally valid recommendations on ERAS4OLT. As a background, we know that ERAS programs can reduce postoperative morbidity, hospital stay and costs without increasing readmission rates or mortality in several areas of surgery, including complex abdominal interventions such as liver resections. To date, there are no standard internationally accepted ERAS protocols designed for liver transplantation. Furthermore, it is not clearly defined which elements of ERAS protocols should optimally be included in comprehensive ERAS programs. Following the Danish Model of Consensus, systematic reviews of the literature are performed for each subdomain of ERAS4OLT by a working group of experts consisting of members of the different project committees. This leads to statements for each subdomain of ERAS4OLT, which will be published. These are then reviewed in a consensus conference where debates with the experts and audience takes place. An independent jury of non-experts reviews the statements and makes final recommendations, which will be published. The subdomains of the deceased donor liver transplantation program includes a total of 24 questions. As an introduction, the history of liver transplantation will be summarized. The lab values and biomarkers optimal for selecting recipients suitable for ERAS, the current evidence on the use of ERAS for liver transplantation, and the association of short-term outcomes with graft and patient survival will be investigated. As far as pre-operative measures, the effect of preoperative assessment, prehabilitation, optimization of nutritional status, and psychological counseling on short-term outcomes after liver transplantation will be investigated. Regarding intraoperative measures, the effect of machine perfusion, the type of anesthetic approach, anesthetic monitoring, cava anastomotic technique, surgical drains and T-tubes, the intraoperative fluid management and transfusion and blood clotting management, analgesia and timing for extubation on short-term outcomes after liver transplantation will be addressed. As far as postoperative ERAS measures, the influence on the thromboprophylaxis and antibiotic management, the timing of drains and lines removal, physiotherapy and rehabilitation management, immunosuppression management, and the timing of discharge on short-term outcomes after liver transplantation will be investigated. The ERAS for living donor liver transplantation program is split into 2 sections, one focusing on the living liver donor and the other one on the recipient after living liver donation. For the ERAS of the living liver donor, the effect of preoperative physiological and surgical workup and psychological counseling, of intraoperative analgesia management and the surgical technique, and of postoperative thromboprophylaxis management and timing of discharge on short-term outcomes after living liver donations are investigated. For eras of the recipient after living liver donation, the optimal graft to recipient weight ratio, how to avoid small for size syndrome, and optimal patient selection are investigated. The modification of portal pressures and flows to enhance recovery of the recipient after living donor liver transplantation are addressed. The individual statements for each subdomain or question of the ERAS4OLT project are created by the working groups using the GRADE approach. We will introduce this approach over the next slides to help support the panel members in their creation of statements. GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation. It represents a transparent and structured system for developing, summarizing, and grading the quality of evidence for systematic reviews and recommendations in healthcare. It was developed by the GRADE Working Group, which is an international team of guideline developers, methodologists, epidemiologists, and clinicians worldwide. The aim of the GRADE approach is to describe the quality of evidence, or the confidence in our effect estimates, for each outcome separately, taking into account the risk of bias, as we know from other tools such as the Cochrane or the Robbins tool, as well as other factors essential in judging quality of a body of evidence, such as imprecision, inconsistency, or indirectness, which we will explore more specifically in the next slides. Furthermore, the GRADE approach provides a comprehensive and transparent framework to develop recommendations based on the developed grading of evidence, as well as estimates of values and resources. It is helpful irrespective of the quality of evidence. However, despite the systematic approach to grading quality of evidence and strength of recommendations, there remains an inevitable need for judgment from systematic reviewers and guideline developers. This is a schematic overview of the GRADE approach, which can be grouped into 3 steps. In step 1, estimates of effect for each outcome are generated. In step 2, the overall quality of evidence for each outcome is rated. And in step 3, the direction and the grade strength is decided on and recommendations are generated. In step 1, the critical outcomes relevant to the specific scientific question are defined. Then, estimates of effect for each outcome are generated, which can be done by calculating pooled summary estimates in a meta-analysis, or, as for most ERAS4OLT questions, a narrative summary of the effect estimates can be generated, as I will show later in this presentation in an example. In step 2, the quality of evidence is rated by making judgments for each outcome across studies for each of the following 5 grade domains, which include limitations or risk of bias, indirectness, imprecision, inconsistency, and publication bias. On this and on the next slide, definitions are provided to help us make judgment and grade the quality of evidence within the grade domains. On this slide, you see definitions regarding the limitations or risk of bias. Here, definitions regarding risk of bias, inconsistency, indirectness, imprecision, and publication bias are provided. Based on our judgments in the 5 grade domains, a summary of findings table is generated using the template provided to the working groups. The quality of evidence is then rated for each outcome across studies, with RCT starting with high quality of evidence and observational studies starting with low quality of evidence, with downgrading or upgrading according to the judgments and to the criteria you can see in the table on this slide. The quality of evidence is then included into the summary of findings table. I will show this in the example that follows in this presentation. In step 3, the evidence to recommendation framework table is generated using the template provided to the working groups. The direction and strength of recommendation is decided on, ranging from strong against to strong for a certain recommendation, as we will also see in the following example. We now, in a step-by-step example, demonstrate how to apply the grade approach in a systematic review without meta-analysis, which will be the case for most ERAS4OLT questions. We use the example question, how do enhanced recovery after surgery protocols affect short-term outcomes in liver transplantation? After performing a systematic literature review, we identified 5 works eligible for analysis. These included 2 RCTs and 3 observational studies. Our critical outcomes we defined as ICU length of stay in days, overall complication rates, overall mortality rates, hospital length of stay in days, and hospital readmission rates, which are summarized for each study in the table shown on this slide. We now make judgments for each of the 5 grade domains across studies, for each outcome separately. In this example, we look at overall complication rates. For the first grade domain, which is limitations or risk of bias, we had the following reasoning for judgment. Definitions to do so can be found on slides 19 and 20 of this presentation. In the observational studies, exposure and outcome measures were adequate and follow-up complete. Eligibility criteria and confounding control was mostly adequate. In the RCTs, even though the type of randomization remained unclear, there was no loss to follow-up or selective outcome reporting. The risk of bias across studies was therefore considered low, yielding a judgment for limitations as not serious. For the second grade domain, inconsistency, our reasoning was that even though slightly varying, the direction of point estimates was consistent, yielding a judgment of not serious for inconsistency. For indirectness, we reasoned that the included study population and interventions were consistent with the target population and target intervention. Conclusions were based on direct comparisons, yielding a non-serious indirectness. Regarding imprecision, we reasoned that the magnitude of the overall sample size was low, and the imprecision therefore judged as serious. For publication bias, we reasoned that a comprehensive systematic review was performed, and publication was therefore judged as not likely. Based on these judgments made for each outcome separately, we now generate a summary of findings table. Let's look again at our example outcome, which is overall complication rates. Summarizing the number of studies reporting overall complications, we had 1 RCT and 2 observational studies, including 104 patients in the ERAS groups and 147 in the control groups. Summarizing the effect estimates qualitatively, we could see that overall complications were clearly lower in the ERAS groups across all studies. The next 5 rows summarize the 5 grade domains, giving a reasoning for our judgments as a footnote, here as a B, where we could see that imprecision was rated serious due to the overall sample size. Based on this summary of judgments, we can now rate our quality of evidence across studies for overall complication rates. The 1 RCT starts at a high quality of evidence. It is downgraded 1 step due to the serious imprecision and upgraded due to the large effect size, resulting in a high quality of evidence. The 2 observational studies start at a low quality of evidence. They are downgraded due to the serious imprecision and upgraded due to the effect size. This results in both a high and low quality of evidence, which can be summarized as moderate overall. We now include the overall quality of evidence for the specific outcome of overall complications in our summary of findings table, again giving the reason for our judgments as a footnote. After rating the quality of evidence for each outcome separately, we come to the final step of the grade approach, which is the recommendations grading. A template of this table has been provided to the working groups. We apply 4 decision domains shown in the column to the left, which lead us to our final recommendations grading. In this example, we address the question of how do ERAS protocols affect short-term outcomes in liver transplantation. The first decision domain includes the balance between desirable and undesirable outcomes or estimated effects, with consideration of values and preferences estimated as typical. Or phrased as a question, given the best estimate of typical values and preferences, are you confident that the benefits outweigh the harms and burden or vice versa? We judge this as yes, with the following reasoning given in the middle column. And I'm reading from the table. The desirable consequences are substantial, including significant reduction of overall complications, ICU and hospital length of stay, and valued highly. The undesirable consequences, inconvenience and burden for patients, including potentially higher efforts for patients and institutions when implementing ERAS protocols, are relatively minor when compared to the desirable consequences, such as morbidity. Definitions of subdomains influencing our judgment are provided in the column to the right. The second decision domain includes a confidence in the magnitude of effect estimates, as we remember from our summary of findings table. For the outcomes of overall complications, ICU and hospital length of stay, our quality of evidence was rated moderately, and for mortality and hospital readmission rates, it was rated low. The third decision domain includes a confidence in values and preferences and their variability. Are you confident about the typical values and preferences, and are they similar across the target population? We judge this as yes, with the reasoning given in the middle column. The fourth decision domain are the resource implications, or as a question, are the resources worth the expected net benefit from following the recommendation? We also judge this as yes, with the reasoning provided in the middle column. Based on these 4 decision domains, we summarize the overall strength of recommendation as strong for the use of ERAS protocols in liver transplantation. Considering all decision domains, the guideline panel therefore recommends that the comprehensive and standardized ERAS4OLT programs should be developed and implemented. As an evidence to recommendation synthesis, we say that we have a high confidence in the mainly moderate magnitude of effect on highly valued outcomes, a moderate confidence that undesirable outcomes are present, and a high confidence in benefits regarding resource implication, therefore suggesting a strong recommendation. We can see that despite the comprehensive and transparent framework and the systematic approach to grading the quality of evidence and strength of recommendations, there remains an inevitable need for judgment from the systematic reviewers and guideline developers, as mentioned earlier. More information regarding the grade approach can be found on these websites. As far as the timeline for the ERAS4OLT project, the systematic reviews and literature screening will lead to the literature being made available to the working groups by May 2021. These will provide statements and manuscripts based on the presented approach by September 2021, leading to the ILTS Consensus Conference in January 2022. The ILTS Consensus Conference will take place in the beautiful Valencia in Spain on January 28th to 29th in 2022. These are the references used in this presentation. Thank you very much for being part of our exciting ERAS4OLT journey, and we look forward to seeing you at the ILTS Consensus Conference in January 2022.